Good evening and welcome to this edition of the Hindustan Times Leadership Summit. It's a very special edition of the summit. It's happening online. We have two very special guests, Dr. Randeep Guleria of the All India Institute of Medical Sciences and Dr. Ashish K of Brown. Both of them are specialists on COVID, which is the topic of the, I won't even say season, which is the topic of the year. It's probably going to be the topic of the coming decade. Dr. Guleria, you've got long years of experience at the front lines of India's medical system. Did you expect such a rapid breakthrough in the vaccine?
No, not at all. And first of all, let me really thank you for inviting me over. And let me say this is a very exciting time. And I think the next year is going to be even more exciting as more and more vaccines start coming into the realm of getting approvals and coming into usage. The success of the two vaccines, the Pfizer and the Moderna vaccine, is very, I would say, encouraging. No one expected such a high vaccine efficacy, and especially in the older age group, which is always a challenge because we have this whole issue of whether the immune response is not going to be that strong. So like I said in the beginning, we're going to have a large number of vaccines which may come. We may not be first off the block in terms of getting the vaccine, but we will have had our overall, let's say, cold chain in place and the distribution channels in place. We need by the time the vaccines are available. But I see in the first quarter of next year, we should have vaccines available in India. The challenge is going to be to prioritize and to give it to the priority groups in a manner that can reach out not only to the larger cities, but to smaller towns and to rural India also, so that everyone can get vaccinated. You see, we are looking at two basic things. One is to save lives, and the second is to break the chain of transmission so that the pandemic comes under control. To do that, the number of people who will need to be vaccinated is going to be significant. And that is why the vaccine program has to keep going on and on for a number of months over the next year before we could say that we've really reached let's say, a plateau in terms of being able to break the chain of transmission substantially throughout the country, and I would say throughout the globe.
Dr. Jha, two related questions for you. The two vaccines which we've been talking about, Moderna and Pfizer, are both based on a new platform, mRNA, messenger RNA. Are you concerned that we've not taken our time to do a proper safety test to see what happens? Because we've never had a successful mRNA vaccine before. And the second question, at the beginning of this, let's go back to February or March. If someone told you that you would have a vaccine in 10 months, would you have believed it? And as a result, do you think we've taken any shortcuts, or do you think everything has happened the way it should happen?
Great. Two very good interrelated questions. So let's talk about safety of mRNA platforms, and then let's talk about whether we've had shortcuts. So I have to tell you, I'm not that worried about an mRNA vaccine. It is a new technology. There are a lot of new technologies that we use all the time, new technologies for drug delivery, new technologies for vaccines. And again, I think we're going to want to watch the safety data coming out of Moderna and Pfizer very closely. But at least as of now, probably 70,000 people have gotten vaccinated between these two vaccines. That's a lot of people. And we will be able to see if there are any significant effects. But to me, the mRNA vaccine is just a delivery platform, and I'm not largely concerned that it's going to end up having any kind of negative effect. And I guess my best way of saying it is, would I be comfortable getting one of those two vaccines? And the answer right now, based on the data, and I'll look at the full set of data when they come out, but based on everything I've seen so far, the answer is absolutely yes. Which then gets to the second question of how did we pull off vaccine development in just 10 months? And did we do shortcuts? And the short answer is there were no shortcuts. Typically with vaccine development, there is a sequential process. You do animal studies, then you go on to small human trials. It takes a while to recruit them. Then you raise money for the next phase. You do very careful planning to say, should we move forward with this or not? And all of it is to really minimize financial losses and to make sure that you're kind of prioritizing things correctly. In this pandemic, we have done things in parallel. So what that has meant is when we started human trials and we did animal trials at the same time, both of them were done, but usually you would do one before the other, and we took the risk of doing both. And so all of the steps that would go into a normal vaccine trial have been done. They've been done much more quickly. We've been willing to suffer financial losses. We've been willing to say we will make a bet on a phase 2 and a phase 3, and we will start producing the vaccine, even if we don't know if it's going to work or not. Those are exactly the right things you want to do in a crisis like this. So I think that's part of it. And then the one last thing I will say, and this is really important for the future, part of the reason we got a vaccine in 10 months is we had spent years developing vaccines for the original SARS virus, for SARS-CoV-1. And so we had quite a head start in terms of understanding the spike protein, understanding what we would target. So it wasn't like we had no idea what this virus was. It was very closely related to its cousin, and that gave us a head start. The reason why this is important is we should not assume that if there is another global pandemic with another virus, we should not assume that we're going to have such a head start. So we actually, as this pandemic begins to come to a close, need to start planning for pandemics where we won't have that head start, and then think about how do we build a system that can generate a vaccine quickly.
Dr. Guleria, while the vaccine is one part of it, treatment is another very, very important part of it. And one of the things we've noticed, and I want your opinion on whether you think this is true or not, is that the data seems to show that most countries have got progressively better at saving lives as the pandemic has gone, right? I mean, in the initial period of the pandemic, the death rate was very, very high. And then over a period of time, at least purely from the data point of view, it seemed as if the progressive death fatality rates were coming down. Do you think that over a period of time, health systems, doctors figured out what to do to save lives?
Definitely. I think as we started off with the pandemic, somewhere in February, March, even in our hospital, there was very little we knew how to manage patients with COVID-19. And a lot of it was done on whatever data was emerging from China. And we were using anti-HIV drugs like lopinavir, ritonavir. There were a lot of other drugs which were being used. And gradually we had more and more data which showed that they were not of much use. We were reluctant to use steroids because the data from H1N1 pandemic and analysis there actually had tried to show that you had a higher mortality if you gave steroids, especially during the early stage when there was viremia. So all of this evolved, and we then realized that, steroids are useful. They really save lives based on the recovery trial. The utility of remdesivir, which has gone from one end to the other, established itself. We also had the use of a lot of other indigenous drugs, which I still would say we need more data in. But we are getting studies coming in, whether it be drugs like ivermectin, the debate on hydroxychloroquine, or the new drug, the drug that we use in India, which has also got a license from the drug controller, favipiravir, which is basically an antiviral for influenza, but has been shown to have broad antiviral effect against even Ebola and other viruses. Also, I think our management strategies improved. We realized that oxygen makes a huge difference, and we have people who may be hypoxemic, but they don't realize it, so-called happy hypoxia. And that even conscious proning, that if you just ask these patients to lie on their stomach or this side, will help in terms of improving oxygenation. So I think over the last few months, whether it be managing sick patients who have sepsis or ARDS, managing moderate patients, or developing a treatment strategy, or placing these drugs in the right time, because there was a time when I remember talking to doctors in India, and they would give a cocktail of all drugs in the beginning, feeling that something will work. But we realize that that's not true. You may have some drugs which may cause more harm, especially if you're giving anti-IL-6 drugs very early, and they can actually lead to superadded infection. So our protocols have evolved, and that has led to a decrease in mortality. We've also been able to pick up warning signs and be able to get people inside hospital early and manage them. But having said that, we still have a significant mortality, and I think it's important, especially the elderly and those who have comorbidities, be monitored closely. It's somehow because of what I would call as COVID fatigue. we're seeing a lot of people not following the general precautions that we keep advising, and many of the young individuals who go out, get the infection, carry it to their homes, where the elderly get the infection, and this can also contribute to a higher morbidity and mortality. So I think it would be very sad for someone to lose an individual now when the vaccine is just around the corner. And it's very important for people to understand that if we hold on for just a few more months, then we could actually save a large number of lives, especially of the elderly and those with comorbidities, because the vaccine will protect them. And that is what these two trials have shown. And that is why it's need to really sort of emphasize more strongly that COVID appropriate behavior is more important now than ever before, because there is light at the end of the tunnel. So you can't say you don't know when this will get over. We know that it will now start getting over sometime next year.
Dr. Guleria, quick question. Steroids, as you said, dexamethasone is one drug which is shown to work. Another one which has been shown to work in the US, monoclonal antibodies. Is there any plan to start using them in India? Or do you think they're just priced out of the market?
So monoclonal antibodies are good. There are two companies which are making them, which have really gone ahead. One, of course, is the Regeneron, which was used by the US president, and the other is by Lilly. They have shown a lot of good evidence, but they're still in the early trials, and we still need to have more data before we can say that they would be useful. Having said that, it's important to remember that monoclonal antibodies is the whole sort of gambit of what we call passive immunity. Convalescent plasma is also a type of passive immunity in a more crude form. Monoclonal antibodies is much more refined as far as that is concerned. It's also expensive. So whether we'll have enough doses to really offer to everyone, whether the cost will be actually something that can be met, and whether if the vaccine comes in, how much would we require these is something that we will come to know over the next few months. But it has some degree of a role, especially in early disease. It doesn't have much role in patients who are requiring oxygen or who are on a ventilator. So the use of and the trials have stopped in using it in this situation. So they have a limited role in mild disease, where we already know that large number of people will recover on their own and therefore may not really benefit that much with monoclonal antibodies. So it, I think, still needs to be positioned properly in the whole, let's say, evolution of COVID-19 infection in an individual.
Dr. Jha, one of the things that we've noticed is that our understanding of the disease itself, the virus, has grown over a period of time. When it all started happening, everyone thought this was just a respiratory tract infection, upper respiratory tract infection initially. And over a period of time, there has actually been literature that suggests that COVID could actually be closer to an autoimmune disorder given the kind of reactions that it causes in the human body than anything else. How well do you think we understand this disease? Do we know it well enough now?
Well, it's a very good question. The short answer is we know it much better than we did 8 months ago. And we understand that it is a far more complex disease than we had initially thought. But unfortunately, there's still a lot we don't understand about this disease. So one of the things that people should understand about COVID is, and I really can't think of any virus that has such a broad range of effects, from 20–30% of people having no symptoms at all ever, to many people having very mild symptoms, to some people getting very sick, to some people dying. Like, there just aren't that many conditions that have this broad range of impacts. So clearly it has something to do with people's host immunity. It has something to do with a host of other factors, maybe how much virus you were infected with. But the bottom line is we are still sorting all this out. So there's a lot in this. So again, actually, let me make two more quick points. One is the way I think about this disease, and you really heard this from Dr. Guleria is that there are two phases of the disease. There's the viremic phase, and then there's the immunologic phase. In the early phase, it acts and functions much more like a normal virus. In the second half, there's this very profound immunologic response that almost makes it look like an autoimmune disease that is triggering. It triggers that in some people, but not others. We've got to sort all of that stuff out. I would say we've made progress, but there's a lot that we don't know about this disease.
Dr. Guleria, as someone who's been in the front lines, what has your experience been with this? I mean, could you just take us through your journey when it first emerged? And you have a lot of experience in this. You're considered India's top pulmonologist. You probably know more about this than lots of other people. What was your first reaction when you saw the first patients? And then over a period of time, how has it evolved?
So for many of us who have been involved in pandemics and looking at respiratory infections have been really saying that we may have a pandemic for a very long period in time. As a matter of fact, I remember in the late 1990s, we had an outbreak of what was then H5N1, which was known as bird flu. And subsequently, of course, we had SARS. And we had a large number of poultry which died, and few individuals also died. And this was a virus which had a case fatality of more than 60%. And we were all worried that if this virus mutates twice, it would have the ability to have sustained human-to-human spread, which is required for any novel virus to cause a pandemic. Luckily, that did not happen. Then we had, of course, H1N1, we've had MERS, we've had the Zika, and so many other viral infections. So I think retrospectively look back, there were enough warning signs to say that a large pandemic is going to come and we need to prepare for it. Unfortunately, let's be very honest that we really didn't put in as much of investment and as much of effort we needed to do for a pandemic preparation. So when it first happened, the first thing that we realized is two things. One is we need to learn more about this virus. And secondly, we need to prepare for an outbreak where you will have a surge of number of cases. So a lot of effort went into really training manpower, a lot of academic activities in terms of understanding about this virus, protecting healthcare workers. We did a lot of workshops, morning, evening, to how do you don and doff a PPE, how do you protect yourself? Because when you're talking of healthcare workers, you're not only talking of residents or doctors or the faculty, you're talking of the nursing officers, the technicians. A lot of them will also go into the COVID area, and you can't have them having an infection. So when you're teaching people infection control, it has to be right down to the sanitation worker, because he's also involved in running that hospital in the COVID area. Similarly, you have to have dedicated areas. We can't have a mixing of patients of COVID and non-COVID. So there was a huge challenge that every hospital faced in the beginning in terms of restructuring its infrastructure into COVID and non-COVID area, even looking at ventilation so that you make sure that there is no chance of infection through ventilation, training your staff, and then developing strategies of having a good supply chain of PPEs, N95, drugs. I remember in India in the early days, there was a huge issue of shortage of PPEs. And then we did a project, we started a little bit of a project which we published, where we tried to look at, can you recycle PPEs? So if you have a PPE which is being used and if it's not torn, can you really get it recycled and can it be used again? We felt it would also decrease the increase in plastics which has happened globally as a sort of fallout of the pandemic. So there were a lot of challenges that we went through each phase as this pandemic evolved. And like you said, treatment strategies were being developed. Every week you would find the protocol would change to some extent in terms of managing mild, moderate and severe cases. What would you do? What is the new thing that has come out? Would you try this new strategy? What is the evidence? So it's been a huge learning curve. And I would say that there's been a huge amount of research which has been done over the last 8 to 9 months. If you look at the papers that have come in, it's actually phenomenal in terms of COVID-19. And for many of us, just to stay in touch with what's happening is become a big challenge, because there is such a lot of research being done, which is very heartening and helping us in terms of trying to really get things right as far as the pandemic is concerned.
one of our columnists actually put a number to it. He said that over the last 8 months, there have been 50,000 papers that have been published on COVID, which is a phenomenal number. But coming to our knowledge of the disease, over a period of time, there have been lots of questions. Some have been answered, some have not been answered. And Dr. Jha, you referred to some of this. Not everyone exposed to the virus gets infected. Not everyone infected passes it on. I don't know whether you saw the Science magazine, the study that was published in Science magazine based on a study of 85,000 people in Tamil Nadu and Andhra Pradesh, which showed that 8% of the people are responsible for 70% of the infection or 60% of the infection, which means this is a disease that depends on super spreaders. And while a lot of questions have got answered, one issue on which there has been a lot of confusion, and right, I mean, every day there are 2 papers on this. It's a question which I'm pretty confused about, so I'm hoping that both of you will be able to shed light on this. So Dr. Jha, you first. Immunity, short-term, long-term, linked to antibodies or not, the fact that antibodies vanish, but then you have another study that says you have B cells and T cells which remember the virus and helps. I'm asking you this also because whether a vaccine is effective or not will also depend to a significant extent on the quality of immunity that a vaccine is able to give. So what's your own sense?
Yeah, great, thank you. Very good question. Let me say a couple of things as a starting point. Immunity is complicated, and it has felt to me that in the last 9 months, everybody has become an immunologist. So people need to take a step back and understand that this is a complex area, but the evidence so far has been largely reassuring. I would say that I look at the data on immunity, I look at all the mechanisms by which we understand immunity, and I'm feeling reassured. So let's talk a little bit more about that. We know across the world that 50, 60 million people have been known to be infected with this virus. There have been reinfections, some reinfections as short as 2 months after the initial reinfection, but those are very uncommon. So what we would expect, I never expected 100% immunity forever. That's not a realistic expectation for any virus. What you should expect, what I was hoping, is that most people would be immune for at least some period of time, ideally a year or longer. What we're finding is almost everybody who's been infected and recovered seems to have some degree of immunity, occasionally not, right? There are going to be exceptions. And what we're finding is that that immunity is durable for at least 8 or 9 months. It might be much longer. We just don't have the experience. We don't have 5 years of experience with this virus. So at this point, what I don't, and by the way, we need to not get worried about studies that show that antibodies disappear or they get very low. That happens with lots of diseases where you still have immunity. So the key point here is immunity looks like it happens for most people. It looks like it's pretty durable for at least 8, 9 months. And if I were at this point betting, I would say most people are going to be immune for at least a year. And by the way, I think that'll happen with the vaccine as well, though we don't know, of course. And so based on all of that, my guess right now is that we may be coming up with vaccines where we have to get a booster shot every year. That's okay. It's not great, but it's okay. Or maybe it'll last longer. We don't know. But I have become less and less worried about immunity over time as the data have come in. And I try to avoid the headlines that I think cause all of us more fear than they do give us, insights into what's going on.
Dr. Guleria, I have an audience question for you. We have a large number of people who've logged on. And this is an interesting question also because I think you've been right there at the center of action. Looking back at the last 10 months, are you happy with the speed and effectiveness of India's response to fight the pandemic? And how ready are we to fight another pandemic in the future?
So I think that response has been pretty good. We've been actually done pretty well in terms of being innovative and have had a very interesting journey. We've written a book on this, as a matter of fact, me and Dr. Gagandeep Kant and Dr. Chandrakant Lahiri on Till We Win, which is actually documents India's journey and battle through these 9 months. But what it basically has shown us is that we are a very resilient nation. When we started off, there was a lot of panic that we would not have enough PPEs, we would not have enough ventilators. We were able to manage all of that. We are now we have the capacity to export PPEs. We started off with saying that we would have very few virology labs which had the capacity to really diagnose COVID-19 using RT-PCR. Now we have more than 2,000 labs scattered all over the country, and we're doing almost 1.5 million tests a day. For our country, that's a huge achievement. So I think there has been a lot of learning that we've had over the past few months. It's shown that we can, if we have the sort of will, be ready for another pandemic. But I would say that there has to be more investment in the public sector. There has to be more involvement of healthcare professionals in preparing, whether it be surveillance, whether it be plans for how do you upscale your infrastructure, so that whenever we have the next pandemic, we learn from this and take it forward rather than making the same mistakes again.
Okay, we have around 5 minutes left, and there are a bunch of audience questions. So I'm going to try and do a bit of a rapid fire here and address it to specific people. Dr. Jha, home tests. Quick opinion on home tests. The first one was approved yesterday. What's your view?
I think it's great. I want to see many, many more of these. I'm sorry that it has taken us so long to develop these things. I wish we had them 3 or 6 months ago. It's going to be a while before they're widely available, but I think it's great and we should have more of them.
Dr. Guleria, what proportion of India do you think will be vaccinated next year? What proportion of the Indian population do you think will be vaccinated next year?
That's a tough question. I hope that we are able to do a large number. I'm sure all the healthcare workers should be, and the frontline workers would be vaccinated. But then we need to also look at the high risk group. It will depend how many vaccines come into the market within the first quarter in terms of regulatory approvals.
A quick add-on. India has deals with 2 of the companies, right? I mean, we have tripartite deals with AstraZeneca and Serum Institute, and Novavax and Serum Institute. Both of those are being made at Serum Institute. Are there plans to strike deals with any more?
So there are already, the Russian vaccine is also being made at Dr. Reddy's laboratory. That is going into also phase 3 trial. And we have our own indigenous vaccine being made by Zydus Cadila. So like I said, we will have a number of vaccines which will get regulatory approval early next year. Depending on the number of doses each of them can produce and what is the efficacy of the vaccine that comes out, we may have that many million doses to give to the population. So it will sort of depend on a lot of factors. But hopefully, I think that by the end of next year, a significant number of the population would be vaccinated so as to actually see a downward trend or maybe have a good control on the pandemic.
Proportion, would you say 30%? Would you say 40%? Would you say 25%?
It's a difficult guess. I hope it is 30 to 40% at least, but I would not hazard a guess.
All right, Dr. Jha, what phase of the pandemic do you think we are in? Right, I mean, it's ebbed, it's flowed. There are some countries which have seen 3 waves, much like the US has. Delhi, which is where we are, the Union Territory, has again seen 3 waves. What phase do you think we are in right now?
Yeah, it's a good question. So I am hopeful that we are sort of in the last big wave of this pandemic, that while things are very bad in the US and very bad in many parts of Europe, India is in a bit better shape than it was a couple of months ago. Much of East Asia is in better shape. And as what will happen is as the vaccine starts rolling out, it will start making a difference unto itself because it will start slowing the spread of the virus, because it will start building up population immunity. And so in a country like America, where maybe my guess is 15 to 20% of people have already been infected, once another 10 or 20% of people are vaccinated, you start getting some of the benefits of population immunity. It's not herd immunity at that level, but it is helpful. So I'm hoping that we're not going to see any more major outbreaks, but you'll see lots of places with minor, small, medium-sized outbreaks happening probably all through 2021, if not beyond.
Dr. Guleria, Dr. Jha said 15 to 20% of the US population has probably already been infected. what do you think the corresponding proportion for India is? Do you think it's likely to be around the same?
I think so. The serosurveillance data did suggest that in certain pockets it was even higher. In Delhi, it was almost to the tune of 25%. And in certain areas, especially the urban slums where there is a lot of crowding, it's close to 40 to 50% of people in. So it has varied from region to region depending upon the crowd density and number of people who got infected. And it's likely to be much lower in rural area where there is the population is more widely sort of spread out. So I think that number would be reasonable for India also. Maybe it's slightly on the higher side if I put it that way.
Okay, final question for both of you, and you can answer it as shortly as you want to. Do you think we've sort of solved this? Do you think we've got the virus licked?
I think the virus is going to be with us for a very long time. And what I would say is instead of we have solved it or beaten it, I would say we are learning to figure out how to live with it. And that with a vaccine, we will learn how to live with it in a way that doesn't cause us the level of disruption that it did this year. But I don't think that the virus is going to go away. I think we're going to be managing it. And what I'm most hopeful of is that we use this very painful year to learn how to do this better next time.
Dr. Guleria?
So viruses have been there on this planet even before mankind or Homo sapiens were there. And therefore to say that we'll have licked it is going to be a little bit too premature. Like has already been mentioned, this is a very smart virus. The more you learn about it, the more you admire it. It goes into your lungs without you even being symptomatic. We have individuals who are asymptomatic, but will show patches on the CT scan. So it really bypasses your defense mechanisms. And you don't realize that you not only have the virus in your nose and throat, but it's gone right into your lungs, and you say that you have no symptoms. A virus which can do that and which can have this whole varied presentation and cause such a lot of systemic manifestation, the extrapulmonary manifestation, is something we have to be very wary of. And as has been said, I think it will stay around for some time. We will have to learn to live with it and be able to control it so that we don't have outbreaks like we've had this year, but it's going to be here for some time.
On that note, Drs. Guleria and Jha, it was a pleasure having you on the opening session. I think we are all a lot wiser about the virus and the pandemic than we were at the beginning. Thank you so much for taking the time out to do this.